But all right, so I think maybe we should get going. And good evening, everyone, and welcome to our University of Toronto Spine Program Journal Club. I'm Michael Fehlings, co-director of the UofT Spine Program. I'm joined by my friend and colleague Albert Yee, who will say a few words as well. And this has been the most extraordinary year, to say it the least. And I just want to commend everyone's resilience and endurance. We will get through this. So we've been trying quite hard to maintain the spirit of the academic milieu, and we've been trying to run about one academic event per month. So this is our second journal club. We had a very good journal club on frailty in September, and this evening's journal club will be hosted by our St. Michael's colleagues. Thank you to Nadia Jabber, our program coordinator, for helping to organize this. I know we're joined by a number of industry colleagues as well. We're appreciative to our industry colleagues, as well as support from the Department of Surgery and the divisions of ortho and neuro surgery. Over to you, Albert, and then I guess we'll introduce Jeff to host the evening.
That's great. So good evening, everyone, and thank you for connecting. And this is our journal club, as Michael has mentioned. And I just want to acknowledge and thank our colleagues at St. Michael's Hospital. So many thanks, Jeff, and I see Howard. We've got Henry, faculty, and Chris, and our fellows from St. Mike's, who have taken really the leadership role to organize the various articles and the topic for this evening. And so I think we've covered many different topics over the years, including sort of degenerative, deformity, trauma, oncology, and I think this is certainly an area that we probably have not covered, I think, as in depth. And so it's great to see this focus on the sports and spine spectrum, and to think about these patients that we do occasionally see from time to time, and certainly are typically quite sort of high functioning athletes and at competitive levels, and can be obviously a bit of a diagnostic therapeutic discussion as it relates to patient-centered care and their specific condition. So thanks so much to Nadia as well for organizing this, to our industry colleagues. And I'll maybe, Michael, did you want to introduce Jeff? And
Sure, I'm happy to introduce my dear friend and colleague, Dr. Jefferson Wilson, and clinician scientist at St. Michael's Hospital. And Jeff will be leading this evening's a journal club, and Jeff will hand over the moderating duties to you. I'd be interested perhaps in the perspectives and what was behind the choice of this evening's seminar. I think it's generated a lot of interest, and then I know you'll introduce your fellows accordingly. So over to you, Jeff.
Right. Thank you very much, and thanks to the Spine Program for the opportunity to present tonight at this journal club. I think we can agree that this is one of the highlights of the academic program for our spine program in general. And I just want to acknowledge my spine partners, Dr. Howard Ginsberg, Dr. Chris Whittu, and Dr. Henry On, and we're very proud of the fellowship program at St. Mike's and of our fellows this year. They're really an exemplary group, and we thank them a lot for putting together the presentation surrounding these 4 articles tonight. We chose this topic because I think we can all agree athletes are a bit of an interesting and sometimes difficult phenotype to manage from the perspective of spinal pathology. And by virtue of the activities that they're involved with, they can have a special proclivity to develop spinal issues, but also the management of these issues when they arise can be challenging because you're dealing with certain aspects and considerations that normally you don't have to consider, such as the demands that athlete will put on their body, obviously depending on the specific sport they're involved with, and also things like return to play come to be an issue, and things that we have to consider in these individuals that we normally don't have to. And just to highlight some of the issues that we deal with in this patient group. So this is a patient that I saw a couple of years ago, and he's a 28-year-old Olympian in track and field, and he had 3 months of right leg numbness and subtle incoordination in his leg, and his exam wasn't particularly abnormal, apart from a right Hoffman sign and some mild grip strength loss. And we saw this individual, he looked like he had 1-level acute disc herniation causing pretty significant cord compression. And there were a number of thoughts that came to mind and issues. Of course, how best to manage this patient, operative versus non-operative. And if we are going down the operative route, what are the surgical options? Are there certain operations that we might want to consider more heavily in this individual? Will that change how we approach the surgical management of this person? Are things like motion preservation more of an issue, or should we be leaning more towards fusion? And then if and when the patient has surgery, what can we tell them about return to play? So this highlights some of the issues we face when dealing with more of a degenerative related condition. Also, we see not infrequently these patients involved with trauma. So this is a 20-year-old hockey player that had a unilateral displaced facet fracture, and he's a bit perched on one side. He came in with a C7 radiculopathy, which was quite symptomatic, and he underwent an ACDF, reduction of the fracture, and he symptomatically did well. But then what can we tell him about when or if he can return to hockey? Of course, we're all a bit concerned about if he were to get checked into the boards again, what could happen. And so these are things we have to manage and discuss with the patient. And of course, there's some heightened degree of angst for surgeons in general when we deal with these high-level young individuals with these spinal issues. Certainly feel a little bit more stressed and a little bit more anxious when dealing with these people. And there's often a lot of background individuals involved, whether it be their managers or trainers and agents, etc., that just make make the situation somewhat more convoluted and difficult from time to time. So to get to the heart of some of the key issues facing this topic, our fellows have looked at 4 pertinent papers relative to the subject. So we're going to start with Dr. Peter Proemmel, who's going to speak about the management of acute lumbar stress reactions in athletes. And we're going to talk, then Manuel Fuetsch is going to go on to speak about ACDF versus arthroplasty. So this is maybe a subgroup of patients where there might be increased interest in performing an arthroplasty because as a young individual, and there may be some concerns about motion preservation and risk of adjacent segment disease if we do a fusion in a young person. So we thought this was topical to address in this context. And then Dhawi Al-Otaibi is going to talk about return to play recommendations based on a recent paper based on a modified Delphi process from the CSRS about returning to collision sports after C-spine injuries associated with those sports. And then finally, Kelechi Eseonu is going to speak about return to play recommendations after CT or L spine injuries. So these should be great papers. I hope they generate a lot of discussion. Of course, if there's any questions from the audience, please do not hesitate to answer or to pose questions through the Q&A function. And perhaps with that, we'll get started with the first paper, and I'll hand the reins over to Peter Proemmel.
Thank you very much. Is it visible?
Looks good, yep.
Okay, perfect. I also like to thank the program directors, Dr. Fehlings, Dr. Yi, and our mentoring staffs at St. Mike's, Howard, Jeff, Chris, and Henry for giving us the opportunity to learn and benefit from their experience and the whole Toronto program. I like to talk about a recent review from the group in Philadelphia about the management of acute lumbar stress reaction of the pedicle and pars in professional athletes playing collision sports. Excuse me. Yeah, so it's the study is a review of the available literature, and in the end, it will give us 4 expert guidelines for the management of these conditions. So starting with the epidemiology of the pedicle and pars stress lesions, it has a reported prevalence of 3 to 6% in adults and a slight higher prevalence in competitive athletes. And coming to collision sports, there's an estimated prevalence up to 20 to 30% in collision sports. There is also a observed male to female ratio 2 to 1 up to 3 to 1 in favor of male. So why are high-level athletes susceptible to acute stress reaction of the pars and the pedicles? We have to take into account that the elite athletes always start their intense training already in their adolescence. This is an age when the maturation of the posterior elements like the pars and the pedicles is not finished yet. It has numerous ossification centers, and the full ossification is ending at the age of approximately 25 years. So during this time, when the pars and the pedicles are prone to injury in the younger age, they already have a lot of stress on these structures. Especially repetitive loads on the pars and especially in the lumbar spine with hyperextension and trunk rotation can lead to fatigue fractures. It's most commonly seen in the L5 lamina with up to 95% and less often in the L4 lamina. Mostly due to the fact that it's the junction of the mobile spine to the stiff sacrum. So there's a big change of from mobile to a fixed part of the spine. And also the sagittal orientation of the L5 S1 facet might play a role and increase the stress on the L5 lamina. And this might also be a reason why it especially occurs in the lower spine. So some risk factors have been identified, like the increased lumbar lordosis, the iliopsoas and hamstring weakness, tight thoracolumbar fascia, also abdominal weakness and thoracic kyphosis are identified risk factors for stress reactions of the pars and the pedicles. And yeah, so the mechanical stress factors I already mentioned, repetitive loads on the pars, and there's also age and sex related risk factor. An interesting paper which was mentioned within this review also figured out that the position of players in American football plays a role on the prevalence of pars fractures or pedicle stress fractures. So the highest prevalence have the linemen. Second highest prevalence have the wide receivers, and also a higher prevalence compared to rest of football players are the running backs. This was quite an interesting finding. So what is the definition of collision sports? There is a definition by the American Academy of Pediatrics. It's a definition that the athletes purposely hitting or colliding each other with high velocity. Example is American football or rugby or hockey. There are the contact sports like basketball or soccer, where the athletes just have routinely contact with much less forces compared to the collision sports. And just to mention, there are also limited contact sports where the athletes or objects just have infrequent contacts, like golf or tennis. The clinical presentation of athletes suffering from stress reaction in the lumbar spine is a gradual increase of low back pain for longer than 4 to 6 weeks. Sometimes it can radiate to the buttocks or dorsal thighs. The patient also reported about the stiffness of the hips and difficulties bending over. There is a clinical test, the so-called Stork test, where the patients stand on one leg and extend the lumbar spine. And if this is leading to a reduced pain on the ipsilateral side, it's considered to be positive. This test is not specific and not sensitive for parts fractures or pedicle fractures, but during the early phase of the treatment, it plays a role. Imaging is the key to the diagnosis of lumbar stress reactions. Historically, of course, plain radiographs play a major role in AP and lateral views, also flexion extension to rule out or to demonstrate instability. There's also the oblique imaging with the famous Scotty Dock sign. Most of us know from written medical exams, maybe. We can see it here on the right side where the I don't know if you can see my arrow, but the neck of the dog, when it's discontinued, then that's a sign for spondylolysis. It has a sensitivity of up to 96% for spondylosis, but is not very specific or sensitive for non-lytic stress reaction in the lumbar spine. The computed tomography was considered as the gold standard for the detection of spondylolysis. It can also identify stress reactions, especially by demonstrating sclerosis of the bone. Then the single photon emission computed tomography has a very early sensitivity for stress reaction by enhancing tracer in metabolic active regions of the bone. It can distinguish between active and inactive bone defects, but the specificity is quite low, as also infections or neoplasms can lead to an increased uptake of the tracer. Nowadays, MRI is widely available, and it has a reported sensitivity of approximately 90% for spondylolysis and stress reactions. In this particular example, the T2 hyperintensity is a sign for bone marrow edema, which is a sign for stress reaction within the bone. It also has the advantage that it can exclude soft tissue involvement like disc herniations or ligamentous injuries, and therefore has the most global overview about the spine conditions in patients with the presenting symptoms. Coming to the treatment, it's most of the patients are considered to have a conservative treatment throughout the literature. The main approach is first to have the patients rested from their activity, which is causing the pain or the symptoms. Of course, analgesia plays a major role. The activity modification is important for most of the authors. Bracing is a very controversial therapy form. I will come to that later. But it's quite often mentioned that bracing for 4 to 6 weeks in an antilordotic Boston collar should be involved into the therapy. And of course, pain-free rehabilitation with focused physical therapy is quite important. I think the return to play talks later will mention that further. Here is an example which was also lined out in the study for an example for the conservative treatment. It's the Watkins back rehabilitation program, which consists of 5 levels with increasing activities in different positions of the athlete. It also is often used in the recommendations of the 4 authors, which I will summarize later as an important part for the rehabilitation of the athletes. There's also the possibility for a surgical treatment of stress reaction in the pars or the pedicle. They are just considered in patients who failed to have a successful conservative treatment for more than 12 months, and if they have evidence of a fibrous non-union of the bony lesion. Here are just 4 examples. On picture A, it's an example for a direct compression screw for the pars defect. Picture B shows a wiring technique for a bilateral pars defect to fix the mobile bone. On picture C, there is a pedicle screw construct with infralaminar hooks to fix the bone. And picture D is a pedicle screw tension band system, which is also a possibility to address these lesions. As mentioned in the beginning, the review tried to summarize 4 recommendations for treatment guidelines, because for these lesions in high collision sports athletes, there are no general guidelines available. So the authors of this paper asked for physicians in the US who actively treat NFL athletes with these lesions. And in this summary, we can see they have something in common, but also they have some differences in their approach to the treatment of stress reaction in the lumbar spine. Regarding the imaging, all 4 groups propose to use the MRI as the primary imaging or as a follow-up imaging. A SPECT is used by 2 groups. The CT is also recommended in most of groups as a follow-up imaging. But most of the authors agree that the MRI is playing the major role in initial and follow-up imaging in these patients. Bracing is still used. Regarding the bracing, it should be said that bracing on the L4 and L5 level is quite difficult, because we still have the mobile sacrum and hips, and to immobilize the lower lumbar spine, bracing should include the hips, and there is no compliance by adult athletes to have bracing, which is including also the hips. So bracing is not a routine in most of the recommendations. So the Watkins group from LA is not bracing. The Dallas group braces if the lesion is at L3 level or higher for 6 weeks. And the 2 other groups, they brace routinely, also in lower lumbar levels, and depending if the patient is pain-free after 4 weeks. The New York group is then stopping the bracing and is going further in the rehabilitation program. Medication, mainly, there is some echo.
Can I ask Laura to mute her?
I think I muted.
Should be good now, Peter.
Oh, perfect, thank you. So medication consists mostly of analgesia, of course. There's some controversy regarding the use of non-steroidal anti-inflammatory drugs, because some authors argue that it might impair the bone healing. 2 groups are using Forteo, so it's a parathyroid hormone which might increase or improve the bone healing. The non-operative further treatment is mostly consisting of stepwise rising of activity and intensity of the exercise. And here the Watkins back program plays a major role in 3 of these 4 recommendations. Surgery is considered just a last resort in most of the groups. 1 group from Dallas didn't do any surgery within the routine of 25 years. So it's mostly considered not to be the primary approach to these lesions of the lumbar spine. So as take-home messages from this review, lumbar stress reactions are commonly seen in high-level athletes. MRI is the imaging modality of choice, and there can be add-ons by CT or SPECT imaging, or also plain radiographs. The conservative treatment is highly successful. Surgery is rare, and there are no established treatment guidelines. And as also elite athletes have it during their training, also the treatment of their pathology is a highly individualized approach. Thank you very much.
Thanks, Peter. Appreciate that. I'm sorry, I'm remiss not to do this. I should have introduced Peter. He's a neurosurgeon from Switzerland. Sorry for not introducing you better,
no problem.
Peter.
Thank you.
So appreciated your talk, and something that probably we don't see a ton, but worthy of discussion, I think. Maybe I'll just start quickly asking you a question. So if you had a patient, basically after reading this paper and learning a bit more about it, the patient presents to you de novo, say with a month or 2 of symptoms and imaging findings commensurate with this sort of injury, what will be your approach when you're in practice? What will you start with?
So everything is starting with a very thorough physical exam and history taking, of course. During this review, most of the papers proposed really to start with plain radiographs after they have the suspicion of a lumbar stress reaction or stress reaction of the lumbar spine. So, but basically it starts with a physical exam.
I mean, more so from a treatment perspective.
Rest is the first measure. So stop from the pain-causing activity.
Okay. Did any of the faculty have any comments, or Dr. Fehlings?
Yeah, so I've seen a handful of cases, interestingly, mainly in ballerinas and gymnasts. And I can recall a few ballerinas with the National Ballet having had an acute pars fracture in the setting of having a few other pars fractures. So that's just just kind of anecdotal. These people, I managed all of these people kind of non-operatively. But what I learned is that this is actually quite common, just as an FYI, in ballerinas and high performance gymnasts as well. Never braced any of these individuals. I'm not really a big fan of bracing, and the approach that I used was kind of to ease off on the on their intensive physical exercises, and then kind of get back into kind of a core strengthening. Most of them were able to return back to high performance, although not all were.
I was also surprised that 3 of these 4 recommendations included 4 to 6 weeks of bracing and inactivity, more or less. So only one group really did the start of the rehabilitation program directly from the beginning of the diagnosis. So they did not have these 4 to 6 weeks of rest, which in my opinion is a reasonable approach.
That's excellent. I think maybe just in the interest of time, we got 3 more papers to get through. We'll continue on, and if we have some time left over, maybe we can continue to speak about this topic. So maybe with that, Manuel, I'll ask you to start sharing your screen. That's okay. So yeah. Manuel Fuetsch is a Austrian neurosurgeon who did his training in Germany, in Munich. And we're happy to have had the opportunity to work with him this year. He's going to be presenting the 7-year results of the PRODISC-C randomized control trial. And we're looking forward to your presentation. Maybe we can have a brief discussion afterwards.
Thanks, Jeff, for the introduction. Can everybody see my slides?
Looks good, yeah.
Great, thanks. So thank you for the opportunity again to the UofT Spine program, for being a fellow here and for being able to do this presentation today. I'm covering the topic of the PRODISC-C total disc replacement versus ACDF for single-level symptomatic cervical disc disease. It's a 7-year follow-up after a prospective randomized US FDA investigational device exemption study. Why choosing this paper? As stated before, pro athletes and amateur athletes constitute a subpopulation for which total disc replacement is often emphasized due to the preservation of motion, the higher range of motion after surgery. The study included patients whose mean age was relatively low, 43 years of age. It also was a single-level disease and consisted of patients with only soft disc herniation. Apart from that, the data from this very study is considered of high level, level 1 data due to its study design. It's single-blinded, randomized controlled trial, multi-center in 13 centers. And the patients show a high equivalence of baseline demographics of the 2 groups. We have a long-term evaluation over 7 years, as stated, and high follow-up rates of over 90%. So 13 sites in the US participated in this study. The randomization was due to non-inferiority design with a 1-to-1 randomization. 228 patients participated, and the subjects were blinded until after surgery. Obviously, the surgical team was not blinded. 103 patients were enrolled in the total disc replacement group, whereas 106 in the ACDF group. And initial treatment was performed in 2003 to 2005. All of these patients had cervical degenerative disc disease and intractable radiculopathy, and the levels that were operated on were C3 to C7, so C7 to T1 was not included. The first study published from this very data was from 2009. The patients were initially followed for 2 years, and there were 2 subsequent studies, one after 5 years, and this very study I'm presenting now where the patient population was followed for 7 years. There were no design changes within these studies. Patient population, as stated, had a high equivalence of the baseline demographics. There was an equal distribution of the sex of the patients, of the age. They were relatively low, as stated, and the race. They were slightly overweight with a BMI of 27, and nearly half of the patients were smokers or ex-smokers, and there was an equivalence in the prior surgical treatments. Preoperative symptoms, especially the arm pain and neck disability index, was the same as well in both groups or similar. The only significant difference was a higher prevalence of neck pain in the patients that were enrolled in the total disc replacement group. What were the primary outcome measures? The neck disability index, neurological success, defined as maintenance or improvement of the neurological status, adverse events, and most important for the interpretation and for the discussion and the conclusion, secondary surgical procedures, including additional fixation and including surgery for adjacent segment diseases. The results of the 7-year follow-up, the authors stated the rate of follow-up rate of over 90%. What is also stated is that 12 patients in the DDR group and 16 patients in the ACDF group did not sign for informed consent, which meant in the end, the TDR group had 79 patients and the ACDF group 73 patients, but still there was no change in the population. All patient-related outcome measures improved after surgery. There was no significant difference between the ProDisc C and ACDF group regarding the neurological success, showing the decompression part of the surgery is successful overall in nearly 90% of the patients. Also showing that patients had a high level of satisfaction, 86 to 83% of the patients. And there was the same extent of improvement as well as the same time course changes and the same adverse event rate in both groups, in the total disc replacement group as well as in the ACDF group. But the difference, or the stated difference, the risk for secondary surgery was 3.7 times higher in the ACDF group, obviously highly statistically significant. This figure shows the mean cumulative function of the risk for secondary surgical procedures, the very difference of the two groups. So in the ProDisc group, 7 patients had to be operated on afterwards, whereas 30 patients had to be operated on in the ACDF group. 6 of the procedures were performed at the index level in the ProDisc group, whereas 19 procedures involved the index level in the ACDF group. Most important, 22 of these procedures involved the index level and or the adjacent levels in the ACDF group. Obviously, the mean flexion extension rate of motion was very low in the ACDF group and was 8 degrees in the ProDisc group, showing that the goal was, surgery was successful and the goal was achieved in both groups, preserving the range of motion in the ProDisc group, whereas leading to fusion in the ACDF group. Radiographic outcomes in the ProDisc group showed 11% of bony bridging with a loss of motion over time, which means 8 of 71 patients. And that's important. The 7-year follow-up showed that this rate is increasing as the time period after surgery increased. So maybe, who knows, that after 10 or 15 or even 20 years, the number of bone bridging with loss of motion would be even higher. Regarding the adverse events, as stated above or stated before, they were nearly the same in the ProDisc as well as in the ACDF group. There was no significant difference. The most common adverse event was neck pain, including shoulder pain, and surgery for device-related events was more often performed in the ACDF group in comparison to the ProDisc group. Medication use at last follow-up, which means 7 years after surgery, was very low regarding strong narcotics as well as the use of muscle relaxants in both groups. Coming to the discussion or the conclusion of the study, the efficacy outcomes are similar between the two treatment groups. Both the TDR group as well as the ACDF groups are both effective and do not differ in patient-related outcomes. But the ProDisc seems to be superior to the ACDF in terms of the rate of secondary surgery, thereby protecting adjacent segments. Obviously, there are limitations in this study. The authors themselves state that there could have been, or there definitely was, surgical bias to some extent in terms of decision-making, when to operate on the adjacent, on the next level, on an adjacent segment disease. We could not find out if fusion was always performed via cage and anterior plating, or only via cage implantation. And only one cervical disc arthroplasty device was assessed. In addition, the authors also state a conflict of interest, stating that authors received payments or services, and one or many authors had a financial relationship to the group. In addition, the FDI, this very study was sponsored by centers, but one has to state that it's always difficult in order when you try to evaluate a new device, who's going to pay for that. Of course, there has to be some kind of involvement of centers in this case as well. Of course, it's a topic that is often discussed upon, and there is obviously additional and much data on that. I tried to figure out 3 additional publications addressing the risk of adjacent segment disease and addressing the differences of arthroplasty versus arthrodesis and anterior fusion for single level spondylosis. So there is data from the UofT group showing in a systematic review and meta-analysis in 2012 that there was a lower incidence of neurological failure and improvement in neck pain in the total disc replacement group in comparison to the ACDF group. And there was a lower incidence of adjacent segment disease, yet it was not statistically significant. 9 randomized controlled trials were enrolled in the study, and up to 2,000 patients were assessed. A similar meta-analysis of 2018 of prospective randomized controlled trials, 14 in number, including 22 papers and including over 3,000 patients, showed a significant difference in the neck disability index and the SF36 physical component scores at 7 years, showing more improvement in the TDR group in comparison to the ACDF groups. And most trials found a significantly less adjacent segment disease frequency in short and long term. So the conclusion of this study, of this meta-analysis, was that TDR reduces the risks of adjacent segment disease in comparison to ACDF. The last study was published in June 2020, so very recent, and was a prospective randomized multicenter, again, US FDA investigational device exemption study, showing radiographic differences at the 7-year follow-up. And they stated that the incidence of this radiographic adjacent segment pathology, which means adjacent segment disease, is lower in patients treated with total disc replacement for both 1 single and 2 level disease, and the total disc replacement is more effective than ACDF in preventing this very adjacent segment disease. But one has to state that the patient-related outcomes clinically remain unaffected through 7 years still. All in all, to show the also local influence of these discussions and of the studies, the Ontario Health Technology Assessment Series, published in February 2019, looked at cervical artificial disc replacement versus fusion for cervical degenerative disc disease, and also stated in the end that total disc replacement is superior to fusion for recovery, return to work, and higher technical success, which most of the other studies did not show. But the total disc replacement lowers the rate of reoperation at the index site and maintained motion. The evidence was, though, insufficient to determine if adjacent level surgery rates differ, but compared to fusion, in conclusion, total disc replacement appears to represent good value for money for adults with 1 or 2 level cervical degenerative disc disease, why it has also been implemented in the care for patients in Ontario. Thank you very much.
Great. Thanks a lot, Manuel. That was an excellent presentation. I guess I might just start with asking you, and then if I could put one of our own faculty on the spot, Chris Whittu, who has a nice practice with arthroplasty, does both quite regularly, ACDF and arthroplasty. Manuel, if it was you that had a single level disc in the neck causing myelopathy, what would you prefer based on the evidence that you presented tonight and your take on this issue in summary?
I do think that the data is relatively clear. There are meta-analyses overall consisting of several thousand patients, and I think the data shows that total disc replacement is superior in preventing adjacent segment disease, and whereas all the other outcomes are obviously the same. I think the question is, do we trust all of this data? Me personally, if you ask me, I would opt for the total disc replacement for myself.
Really?
Yeah.
I guess I might ask the faculty. My concern with this data has always been the revision surgery rates, particularly amongst the fusion group. We don't really get a lot of indication about why the surgery was performed, why the revision surgeries were performed, for what indication, and when under what circumstances. And if you actually look at this paper, most of the revision arthrodesis were done primarily at the index site, but then extended to involve the adjacent segment. So one wonders if maybe these patients had a radiographic non-union and the surgeon went back to fix it and also included the adjacent segment in the absence of true symptomatic adjacent segment disease. So interested to hear what the rest of the faculty think. Dr. Fehlings? Yeah,
this paper was presented at the CSRS and was the subject of rather intense discussion. And on the discussion, this very point came out, and a lot of it has to do with care pathways. And so the care pathway, and a lot of these patients were from the Texas Back Institute. So the care pathway was, if a patient had an ACDF and they had residual pain, they would undergo a posterior fusion, many of the patients. If the patients had a total disc arthroplasty and they had residual pain, they would undergo injections. And so many of the secondary surgeries were for presumed non-union as a result of residual pain. So that isn't so clear from the article. My own sense from looking at the article is that it's sort of a trade-off. There probably is a slightly reduced risk of adjacent segment degeneration, but you have to bear in mind then that there will be a proportion of the patients in which the implants will have to be replaced themselves. I mean, I think overall it's a good procedure, but I think one needs to evaluate the evidence with your eyes open, for sure.
Any other comments from Chris or
Well,
Howard? Or
yeah, Jeff, maybe I'll weigh in quick because I do them. I'm very selective in who I operate on, so I don't do a lot of them, but I do them. I do genuinely believe, I think the index level reoperations, as Dr. Fehlings alluded to, are biased in many ways. Many people point to the inherent biases in the paper and the sponsorship of the studies and everything else that comes along with that. And I think that may influence index level reoperation rates, but I do genuinely believe that this is some of the best evidence we have demonstrating that adjacent level degeneration is significantly reduced and adjacent level operations are significantly reduced. And if you plot out all of these trials and you look at the meta-analysis, Jatan did a very nice one recently, actually. If you look at the curves, they really start to diverge between 4 and 5 years out from the index surgery. and those surgeries are adjacent level degenerations, and I find I'm pressed to find a way to explain sponsorship bias and industry sponsorship money influencing a surgeon's decision or another surgeon decision 5 or more years out from a study. So when I talk to my patients, I tell them I anticipate their outcomes will be the same, except for the risk of a subsequent surgery at an adjacent level. I genuinely believe that they have a significant reduction in that and that alone. And that's what I tell them, and they can,
Interesting.
they can
Okay.
decide from there.
Excellent. Joel, you look like you have something to say.
I was just, well, I think that the authors made a very telling point when they said that the surgeon bias in, you know, the decision making to perform or to do a revision surgery is a limitation of the study, which has been addressed by others already. But if in the same limitations, you're talking about the financial benefits or the sponsorship of companies, and yet they're saying on their own hand that yes, it's probably affected my decision making on fusing adjacent levels, which will certainly puts a thumb on the scale when you're trying to evaluate or compare one versus the other. And they're sort of saying they're doing that. So, but I do agree with Chris's point that maybe at 4 or 5 years, that's not really, well, actually it still probably has something to do with it. But the other point was that when you're looking for justification that CDRs are better by using all these, like a meta-analysis, every single one of the studies in the meta-analysis, I can't think of any, if maybe there's one, but they're all industry sponsored. So they all have the same sort of limitations. So I think that real objective data still isn't out there. And another point is that even though there is radiological evidence of adjacent level disease, the clinical difference still has not been established that there's a big difference clinically. And I think that's, you know, the way I look at it. And there's a difference between radiological adjacent level disease and then clinical adjacent level disease. So if you ask me, what would I have? I would have an ACDF.
Excellent point.
Is anybody doing disc replacement, cervical disc replacement? Anyone else? Anyone tried it? Yes, we've tried it. But I just wonder who else is doing the procedure, and if they did it and stopped, why they stopped.
I was involved in the development of the Discover disc, which was the artificial disc that DePuy Synthes developed, and it was taken off the market not because of problems or failures, but there was high rates of HO, heterotopic ossification, fusion, and the long-term follow-up rates of the ProDisc C also showed high rates of fusion. And DePuy Synthes ended up taking ProDisc C off the market. So I think the technologies are evolving though. So, you know, I was a senior author in the 2012 meta-analysis that was alluded to earlier in the talk, but the technologies are better now. So I think that the technologies are getting better. I think, as Chris has indicated, I think there is a narrow indication, but it's quite narrow, I think. And I think one needs to be quite cautious in applying it in people with spondylosis, because I think what goes on to, you know, these people end up going on to have a fusion anyway. So I think people with a, you know, very soft disc, no other disease. Jeff, I was going to ask you, that patient that you presented who had normal discs and cord compression with that disc, how did you manage that patient?
Yeah, so I ended up offering him, and he obtained multiple opinions.
I'm sure, yeah, I'm sure he did.
In Canada and the US. and he ended up getting about 5 different surgical opinions, and I actually ended up offering him an ACDF, and then he kind of went radio silent, and I learned that he had a disc replacement in New York City by one of our colleagues, and I don't think he's returned to sports yet. So anyways, it's just interesting. I think he was quite seduced by this concern about adjacent segment, and was very concerned about that impacting his career down the road. So
yeah, it's an
Anyway,
interesting consideration. I guess one of the issues here as well is, and I might ask Chris, Chris, if you had, say, a high performance athlete who was, say, a hockey player or a professional football player, say a very violent collision sport, would you have any concerns with regard to arthroplasty versus fusion in that type of patient, or would you be confident enough in the ability of the arthroplasty to withstand those kinds of forces?
No, I actually would have some substantial concerns in that population. I think I would have done exactly what Jeff did and offered a 1-level ACDF. I think that these disc prostheses, to my knowledge, are largely untested in high-level collision athletes, and you just have to skim through the literature. There are certainly some impressive pictures of these prostheses failing under normal circumstances, and I can envision a high load, high strain certainly causing a quite catastrophic failure. So, I mean, Peyton Manning came back and won a Super Bowl after his ACDF. So I think I certainly would not. I would have done exactly what Jeff did and offered a 1-level ACDF.
Great paper. We could maybe highlight. Yeah.
Just one last thing. So I just want to just comment that we have a paper that we actually submitted to CSS, and we're writing it up right now, and it is a review in the province of Ontario of all the CDRs, and we did a comparison to the ACDFs, and it's a 13-year follow-up. So it is, one of the benefits is that it's purely not, there's no bias in it at all. There's no financial incentive at all. And the results basically show that, and it's a 13-year follow-up, that the revision rate between the CDR and ACDF is about 8% for both of them. Let me just look at the number. It's 7.5% for ACDF and 8.9% for CDR. Looking at the total revision rate, or ones that have been revised, either the same level or adjacent level at 13 years. So the data is on this somewhat different than what you're presenting there. So
interesting. I think that's, I guess, an example of efficacy versus effectiveness, in the real world, how it plays out. I guess this highlights a need for maybe a dedicated arthroplasty journal club sometime in the future. So maybe we can organize that. Maybe in the interest of time, we'll move on to the next paper. So pleased to introduce Dr. Dhawi Al-Otaibi. He's a neurosurgeon who's with us visiting from Riyadh, Saudi Arabia. And Dhawi is going to speak about guidelines surrounding return to play in patients who are involved with collision sports based on recent CSRS analysis and Delphi process. Dhawi, are you able to share your screen?
So, yeah. Is it?
Yeah. Let's just see here. Yep, we can see you.
Thank you for the introduction, and I feel fortunate to be in this high academic fellowship training program. I will speak about update return to play recommendation for collision athletes after cervical spine injury. A modified Delphi consensus study with the Cervical Spine Research Society, which was published in Neurosurgery Journal 5 months back. So to introduce the topic, the collision sport have a high inherent risk of injury. with estimates reporting 9 to 15 of over 12,000 new cases of spine injury per year in the United States, which is attributed to sport. Spine injuries associated with football, American football, are common, with the study suggesting between 7 and 10 of injuries in National Football League level athletes involves the head, neck, and spine, not including, of course, concussion. Moreover, estimates suggest 35 to 49% of collision sport spine injury that affect cervical spine and result in nerve injuries in 46% of population, muscle injury 22%, disc injury 6%, and contusion of the spinal cord 2%, and fracture of the cervical spine in 2% of the affected population. So objective of this study is to utilize the modified Delphi process with the Cervical Spine Research Society to formulate actionable statements and to establish updated consensus on return to play for provider caring for collision athlete with cervical spine injury. So literature review result and for the first round, so anonymous online survey sent to CSRS members, which was composed of 14 clinical scenarios and 38 related questions involving cervical spine injuries in football player, which was sent and results were reviewed by the CSRS members and NFL team physicians. And they came up with 13 consensus statements were developed. That was concluding the first round, and in the second round of the study of the method, the statements were administered to the attendees at the CSRS annual meeting in November 2018 for voting on these statements, and consensus recommendations were developed. Level of recommendation were divided accordingly, so simple majority, which was 50 to 59, and that was labeled as no consensus. Super majority, which is 60-70, and labeled as a weak consensus, and super majority, which was 71 to 94 as a strong, and unanimous, which was 95% to 100% agreement, indicating the strongest consensus. However, in the second round, there was a concern regarding return to play after two-level anterior, two-level ACDF, and the third round online anonymous survey sent to focused group of NFL affiliated spine surgeon. This table give the demographic of the first round. And we can notice there is a 48 experts involved. 42 of them are orthopedic spine surgeon, and 6 are neurosurgeon, with 12 member identify themselves as whether in the college football or NFL league. So the recommendations, there were 13 clinical recommendations. This is for the second round, and voted by 95 attendees of the 2019 CSRS annual meeting, and the average engagement was of around 71. 64 identified as an orthopedic spine surgeon, and 3 identified as other. 28 did not identify their subspecialty. Additionally, 17 out of the 95 identified as actively caring for professional collision athletes, and 63 out of the 95 identified as having involvement in the care of competitive collision athletes. From the 13 recommendation surveyed, 8 statements achieved a strong consensus, 3 achieved weak consensus, and 2 achieved no consensus. Of interest, there was no significant difference in response between professional and non-professional sport team affiliated physician. So this table represents the first statements regarding which was based on severity of cervical spine stenosis. And the statement was following an episode of transient paralysis, an asymptomatic athlete with no T2 signal changes and the spine canal diameter more than 10 millimeter are allowed to return to play, but those with the canal diameter less than 10 millimeter should be taken on case-to-case basis. There was a strong consensus agreement with this statement in all position and in the NFL or college football affiliated physicians. The second statement was following an episode of transient paralysis, asymptomatic athlete with resolved T2 signal changes and the spine canal diameter more than 13 millimeter are allowed to return to play, and those with canal diameter between 10 and 13 should be considered on case-to-case basis, and those less than 10 should not return to play. There was agreement on all positions and weak consensus in the affiliated physician. The third statement, following an episode of transient paralysis for asymptomatic athletes with continued T2 signal changes and spine canal diameter more than 15 millimeter, return to play should be taken on case-by-case basis, but those with canal diameter less than 13 millimeter should not return to play. There was weak consensus with this statement from all physicians. However, with the affiliated, there was a strong consensus. The last statement regarding, which was based on severity of cervical spine stenosis, following an injury of asymptomatic athletes with no history of transient paralysis with continued T2 signal changes and spine canal diameter more than 13 millimeter, return to play should be taken on a case-by-case basis, but those with canal diameter less than 13 millimeter should not return to play. There was no consensus in both groups. If we move on now regarding athletes who have either history of cervical trauma or had a history of surgery, there was 6 statements. The first statement is asymptomatic athletes with no T2 signal changes after a solid 1 to 2 level ACDF are allowed to return to play, but a 3 level ACDF should not return to play. There was a strong consensus in both groups for this. In the second statement, asymptomatic athlete with continued T2 signal changes after a solid 2 to 3 level ACDF should not return to play. However, in 1 level ACDF should be taken on a case-by-case basis, also received strong consensus. Third statement, athletes with pseudoarthrosis following a 2 or 3 level ACDF should not return to play, but pseudoarthrosis for 1 level ACDF should be taken on a case-by-case basis. There was no or weak consensus for this. The fourth statement is asymptomatic athletes with a solid fusion after compression fracture, burst fracture, or facet fracture with no instability and no T2 signal changes are allowed to return to play. Interestingly, it received unanimous consensus on the affiliated team physician, and also among non-affiliated team physicians. In patients who are asymptomatic athletes with a solid fusion after cervical spine fracture and no T2 signal changes following a 1 or 2 level ACDF or 1 level posterior fixation are allowed to return to play. There was weak consensus in all physicians. However, among affiliated physicians, there was strong consensus. And lastly, following an episode of transient paralysis, asymptomatic athletes with no T2 signal changes following 1 or 2 level ACDF are allowed to return to play, but following a corpectomy or posterior cervical surgery, return to play should be taken on a case-by-case. There was strong consensus in all position. However, in affiliated position, there was a weak consensus. Now we'll talk about the third round regarding the two-level ACDF among NFL-affiliated physicians. So the first question, obviously, do you take care of American professional football players? The answer is yes. Would you allow an asymptomatic player with full range of motion, no neurological deficit, and no T2 signal changes on MRI, with a solid one-level ACDF to return to play in American football? The answer was unanimous, 100% agreement. However, when it comes to same statement of two-level, the agreement shifted to 50% and 50% disagreement. Additional consideration and return to play guidelines. Athletes with a prior non-operative or operative treatment for cervical spine pathology, with the exception of stinger, should undergo a screening MRI prior to playing a competitive collision contact sport. Interestingly, there was a weak consensus among affiliated physicians. However, there was a strong consensus in all physicians. The second statement, athletes who experience their first stinger with rapid resolution of symptoms do not require an MRI. However, an MRI should be obtained after a second stinger. There was superior majority with weak consensus in all physicians, and NFL affiliated physician strong consensus. And the last statement was athletes who are asymptomatic for less than 5 minutes following a stinger are allowed to return to play, but for those with symptoms lasting more than 5 minutes, return to play should be taken on a case-by-case basis, and it received strong consensus from both groups. So accepted return to play recommendation in collegiate athletes after cervical spine injury have been difficult to develop due to the nature of the injuries and lack of the number of patients. Systematic review of return to play and cervical injury by Nagoshi and colleague in 2017 noted lack of evidence and resorted to expert opinion. France and colleague in 2016 performed a survey of spine trauma surgeons treating cervical spine injury to provide recommendation regarding return to play. Based on a limited consensus and expert opinion. Their study pulled 25 surgeons from spine trauma study group, and they used 10 clinical scenarios of athlete injuries and asked to identify return to play recommendation. Actually, their study did find consensus regarding consensus of return to play in high contact sport in the setting of cervical cord neuropraxia with full symptoms resolution and no spinal canal stenosis. However, there was a variability in recommendation in more complex scenarios with persistent symptoms or spinal canal stenosis or previous history of cervical fusion. So due to the lack of research on the topic and weak consensus, the authors of this article sought to develop improved guideline based on a proven regularly used method in the medical literature for developing and measuring consensus. So regarding recommendation in collision based on severity of cervical canal stenosis, they defined it as absolute cervical stenosis if the sagittal spine diameter is less than 10 millimeter, and relative stenosis defined as less than 13 millimeter. T2 signal hyperactivity is an important factor to be considered. It generally indicates traumatic or edema or inflammation of the spinal cord with persistent changes indicating neurodegeneration or demyelination. Temple and colleague investigated these imaging changes regarding and concluded that if the athletes are asymptomatic with normal neurological exam and no spine instability on imaging, return to play should not be contraindicated. Also, clearing an athlete for sport-related activity should not depend upon resolution of T2 hyperintensity changes. Torg et al. Find an interesting that cervical stenosis and stable spine do not predispose athletes to catastrophic injury, and return to play should not be obstructed. So in the study, the result of consensus survey recommend that asymptomatic athlete without T2 signal changes on cervical MRI and without evidence of absolute cervical stenosis, or those with resolved T2 signal changes and without any evidence of cervical spine stenosis, are allowed to return to play. Also, asymptomatic athletes with no MRI changes and with evidence of absolute cervical stenosis, and those with resolved MRI changes and relative stenosis, or those with continued T2 signal changes and without evidence of any cervical stenosis, are allowed to return to play based on a case-by-case evaluation. And in athletes with persistent T2 signal changes and any form of cervical stenosis, or those with resolved MRI changes and absolute cervical stenosis, should not return to play. And we'll talk now about the recommendation in collision sport after cervical spine trauma or surgery. There are several previous studies reporting outcome after cervical spine surgery and professional athletes. Mostly, however, are for one level ACDF would return to play within 1 year. However, when it comes to two-level ACDF, there is scant of, or posterior surgery, there is a scant of literature on this topic. In this study, this consensus study determined that asymptomatic athlete without T2 signal changes on MRI following a 1 or 2-level ACDF would be allowed to return to play. However, a corpectomy or posterior cervical surgery return to play decision should be made on a case-by-case basis, and 3-level ACDF should not return to play. Moreover, 1-level ACDF with continued T2 signal changes are not completely contraindicated to return to play, and that their status should be evaluated on case by case. However, 2-level ACDF, no return to play when there is high T2 signal changes in their images. Healed fractures without instability or MRI changes should be allowed to return to play, even in the setting of surgical intervention with 1 or 2 ACDF or 1-level posterior cervical fusion, as long as there is solid fusion, no persistent MRI changes. And remarkably, there was a unanimous consensus among participants who are professionally team affiliated regarding the return to play with the solid fusion. Although the consensus was reached regarding 1 or 2-level ACDF in various scenarios, various respondents voiced concern for 2-level ACDF in professional athletes. So, as we mentioned, the third round questionnaire was done in attempt to appease this concern, utilizing an anonymous survey of 8 surgeons with confirmed involvement in NFL. And as we stated, it showed 50% would not allow return to play, even in solid fused 2-level ACDF, who in athletes who are asymptomatic with full range of motion and no neurological deficit or MRI T2 signal changes. And that is because, given the risk of future injury and long-term consequences, we should take care about any return to play recommendation in this particular patient's population, and need to be considered jointly by the treating physician and the player on a case-by-case basis. So, additional consideration for return to play in collision sport athletes. Wang and colleague studied NFL scouting combined participant and determined that athletes with a history of cervical spine injury have significantly shorter career and play in a fewer games compared to controls. Schroeder et al. Determined that professional career outcome depend on the type of cervical pathology an athlete may have, and conclude that each player with a history of cervical spine disease should have individualized evaluation to ensure productive and healthy NFL career. In this study, there was agreement with strong consensus that athletes with a history of cervical spine pathology warrants a screening MRI prior to collision sport participation. And interestingly, the professional sport affiliated participant also agreed with this statement, albeit with weak consensus.
Okay, That's great. Dhawi, maybe just in the interest of time, maybe we'll just, I know it's a hard paper to get through because there's so many different considerations, but maybe just in the interest of time, we'll leave it there for now. I think you did a great job of reviewing that, and there's a lot of controversy, right? So thanks a lot for getting into that. Maybe we'll just, we'll move right to Kelechi's talk, if that's okay. Are you able to share your screen?
Yeah, perfect. Give me one moment.
No problem. Thanks a lot, Dhawi, for that great review.
You're welcome.
So maybe just by way of introduction, Kelechi is a orthopedic surgeon who is visiting us from the UK. And Kelechi is going to continue on talking about return to play after CT and L injuries. And Kelechi, maybe just in the interest of time, we have about 10 to 15 minutes left, so don't mean to rush you by any means, but maybe just keep that in mind, okay?
Sure. Okay, great. Thank you so much for having me. I'll just get straight into it. So I'm going to talk a bit about return to play recommendations after CT and L spinal injuries, including fracture. I looked at a comprehensive review published back in 2016 in Spine Health by a multi-center team. Of note, Lawrence Lemack there at the end, I believe, is the Chief Medical Officer for the MLS Major League Soccer. In the UK, obviously, which I'm more familiar with, there have been a number of controversies recently with physicians returning players back to sport more quickly than possibly they should have, mainly because of financial concerns. And I think that's one of the reasons this is being more and more looked into, is that there can be sometimes a bit of a perverse incentive to get players back into playing more quickly than possibly would be indicated otherwise. So trying to get some sort of standardization. So this study was a non-systematic clinical review, so level 4 evidence, looking at the evidence on cervical, thoracic and lumbar spinal injuries. So by way of background, so incidence of spinal cord injuries around 40 cases per 1 million Americans, so around 12,500 new cases per year, with athletic injuries being the third most common cause. Now, clearly elite athletes are a very distinct group from more recreational athletes. The incentives to get back, both from a team and a personal point of view, are a lot greater, especially from a financial point of view. So that can mean sometimes that I guess that long-term concerns of patient well-being in the longer term can sometimes come secondary to shorter-term financial considerations. Up to 70% of college football players experience burn-ins or stingers during a 4-year college career. And there have been moves, especially in the NFL, to outlaw certain sorts of tackles that are thought to increase the risk of long-term injuries, especially head-first tackling and the horse collar tackle as well, which has recently been outlawed. This study aimed to review the available literature on return to play guidelines after spinal injuries, both those treated surgically and non-operatively, and also to try and provide a review on current guidelines from return to play after all these sorts of injuries. So in the cervical spine, the recommendations from this paper were mostly based on these three studies from Torg et al., Cantu et al., and Alex Vaccaro, who's been discussed before. They divided up all these patients or players into 3 groups. So firstly, those in whom there was no contraindication to return to play, so no increased risk of serious injury. Group 2, which I think is, as we've heard from Dhawi's talk, the largest group sometimes, with relative contraindications, but no clear evidence of increased risk, so a kind of grey area. And the third, in whom there's an absolute contraindication with a clear risk of serious injury going forward. And this is quite a busy slide here. There are a few things I think are worth noting here. So the group in whom, one of the group of patients in whom there was thought to be no contraindication of return to play were patients who had single level ACDF with evidence of fusion. And similarly, those who had 2 or less stingers in the same season. And similarly, those patients who had single or multi-level posterior cervical micro laminoforaminotomy. In the relative contraindication group, as I think we took from Dhawi's talk, were patients who had 2-level ACDF, and I think 2-level ACDFs are probably where a lot of the controversy lies, and also patients who had 3 or more stingers in the season. Now, obviously, the diagnosis of a stinger is largely from a history and from a patient volunteering that information. And I guess something to think about would be, the incentive for let's say, a college athlete who's in their final year trying to get drafted, the incentive for them not to actually reveal in their history that they had symptoms they knew correlated with a stinger, if they knew that there was a contraindication to return to play, is probably quite significant and probably something to bear in mind. In terms of the absolute contraindications, there are quite a few mentioned here. I think 3-level ACDFs, mostly considered to be an absolute contraindication to return to play, as well as ongoing cervical spinal abnormalities noted on MRI scan. But if we remember from Dhawi's talk earlier on, in those patients, for example, who had a previous single-level ACDF with ongoing T2 signal change on MRI scan, I think those sorts of patients are those in whom there may be some disagreement about return to play if they were indeed asymptomatic. Now, stingers and burners, as we know, are caused by injuries to the cervical nerve roots, resulting in transient loss of sensory or motor function, and generally last between seconds to minutes. Obviously, a number of other diagnoses need to be excluded, which is represented here by this image, which I'll skip over for the sake of time. But obviously, in patients in whom one thinks that they may have a stinger or a neuropractic type injury, obviously more concerning diagnoses such as osseous fracture and indeed ligamentous instability all need to be excluded. In terms of the consensus on stingers and burners and return to play, I think it was generally recommended from this paper that patients who had who were completely symptom free and who had full strength and range of motion would be safe to return to play if there's no evidence of other injury on plain radiograph or 3-dimensional CT or MRI scan. But those who had 3 in the same season, then that would count as a relative contraindication, which should be dealt with on a case-by-case basis. There's a bit of controversy, I think, about the relevance of the Tork-Pavlov ratio, this ratio of the canal to vertebral body width. A number of papers which suggest that in American football players, especially who have large vertebral body widths, they may have a naturally reduced torque ratio, and so this possibly isn't useful as a screening tool. Cervical cord neuropraxia can present with transient quadriplegia and quadriparesis, and so complete resolution of symptoms by this paper is recommended as being an indication for return to play. In terms of cervical disc herniation, this paper recommended that asymptomatic disc disease seen on MRI scan was not a contraindication to athletic participation in patients who had not previously had any operative intervention at all. Whereas symptomatic disc herniation was. The paper didn't go into detail about the exact symptomatology that would count as a relative or absolute contraindication. So I think that possibly was a bit of a limitation of this point that was made here. In terms of the indications for surgery, they recommended that this should only be considered in patients who had progressive neurological deficit or those who had established myelopathy, rather than being a reaction to any radiological findings. So in terms of summary of their return to play recommendations, I think Dhawi covered it very nicely earlier on. This review was a little bit more vague, I think, than his study, but essentially summarized that there was really no consensus overall about especially 2-level ACDFs, but there was a bit of confusion about generally about cervical spinal injuries, but that point 2 was very important, that there should be an individualized approach considering the mechanism of injury, the anatomical location of injury, and the patient recovery, and that at a minimum patients should have a full and pain-free range of motion with full strength and no neurological findings before return to play. I think the last point's interesting. So obviously, I think if you speak to most high-level elite athletes, especially in the NFL or playing Premiership rugby, the number of them with pain-free range of motion, even at their baseline, would probably be minimal. So I'm not sure the utility of this last point here, but it's one of the things that they mentioned. Thoracic spinal injuries are a lot less common. The thoracic spine has a larger ratio of spinal cord to spinal canal diameter. And there's a lower instance of compression fractures and other fractures in this area. Burst or chance fractures in the thoracic spine were mentioned as an absolute contraindication to athletic participation in the association with ongoing neurology. And this penultimate point here, I think, was quite interesting, that in patients who'd had spinal fusions which bypassed or stopped at transition zones in either the cervicothoracic or thoracolumbar regions, they were thought to be an absolute contraindication to participation in contact sports such as rugby, hockey, and American football. And that was based on a paper from Neurosurgical Focus in 2006. When considering the lumbar spine, the recommendations from this paper were largely from two studies from the Clinical Journal of Sports Medicine from 2005 and 2006. And what they tried to do was to create a kind of all-encompassing idea of when patients could return to play after various sorts of pathologies in the lumbar spine. So if we look at the herniated disc population, probably I think the most common that one would see in clinical practice. Patients who'd had a percutaneous discectomy or microdiscectomy were thought to be safe to go back to collision sports from 2 to 3 months for percutaneous disc and from around 4 to 6 months for microdiscectomy to contact sports. Patients who'd undergone single level fusion were thought to be fit to go back to play to collision sports to non-collision sports at 1 year. But they actually made a recommendation that for patients who were going back to full contact sports such as ice hockey, football, and rugby, that they would not recommend a return to function. Return to play. In patients who'd had spondylolysis, they recommended 4 to 6 weeks for non-contact sport, and then more of a clinical assessment in terms of return to contact sport. So essentially, patients having returned to full range of movement and pain-free extension before being able to return to play. For those with slips, they recommended pain-free extension as a marker for return to play for grade 1, and then for grade 2 or greater who'd undergone fusion surgery, they did not recommend return to play to contact sport and recommended 1 year for a return to non-contact sport. In patients with lumbar stenosis who'd undergone fusion, again, they didn't recommend return to contact sport. And in patients who'd undergone laminectomy, in patients who had no neurological symptoms or instability, recommended 4 to 6 months as a suitable duration before return to play. The Professional Athlete Spine Initiative papers from 2011 looked at rates of return to play to American football after single level lumbar discectomy. And they reported overall rates of return from around 81 to 89% by 12 months, with a mean time to return to play of 5.3 months. So using the recommendations for this study, I think certainly they recommend that patients who've undergone lumbar fusion often will not be able to return to contact sport, whereas patients who've just undergone microdiscectomy procedures for disc herniation have a high instance of being able to safely return to play. Just going to spondylolysis. So at the bottom here, we can see that this study reviewed 261 patients, 261 specialists at the SRS, and found that in this group of patients, 27 to 36% of surgeons allowed a return to contact sports such as ice hockey, American football, and rugby at 1 year post-operative. This pathology obviously is more commonly seen in skeletally mature individuals, especially NFL linemen or college football linemen, and people such as dancers, and most commonly seen at the L5 level, and most commonly actually managed non-operatively. But in those patients who were managed operatively, they were thought to be able to return at 1 year. Just going now to lumbar stenosis, I think this paper was very quite vague, actually, I would say, about the recommendations from Fusion for single level, 2-level, and so on. They essentially said all patients who'd undergone any Fusion surgery possibly would be a complete contraindication to returning to contact sport. However, then in the discussion later on, they mentioned that in patients who were completely symptom-free, if they had a confirmed fusion on CT scan after having had a single level rather than 2-level fusion, it may not be a complete contraindication to return to contact sport. So I think even within this this one paper from different parts of the paper, there was a bit of confusion or a bit of controversy about whether or not patients who'd undergone single level fusion rather than 2-level fusion will be able to return to contact sport if they'd had confirmed fusion on a CT scan. So I think the 4 fundamental return to play that this paper outlined were essentially patients being pain-free, having full range of movement, having full strength, and having no evidence of neurological injury. But I think one of the major takeaways I took from this paper that at present really there aren't any consensus guidelines, I would say, especially in the lumbar spine on return to contact sport. And if you speak to various physicians and various specialists who look after athletes from different sports, the consensus will be very, very different. And I think that reflects in what we can see underneath here, the strength of recommendation taxonomy, which essentially said that for all of these 3 things, so return to play recommendations, absolute contraindications, that there was a level C grading of evidence. So just consensus disease orientated evidence based on expert opinion rather than based on good quality evidence. So I think one of the major takeaways would be that this is really a field where more work needs to be done to try and establish a consensus across different sports and make sure that we have clear guidelines going forward. Thank you very much.
Thank you so much. It's a lot to get through, a big topic. So thank you for summarizing that so nicely. I'm sensitive to the fact that the hour is getting a bit late. Any last minute comments or questions from any of the attendees or panelists?
Excellent job to all of the speakers. A really kind of interesting a topic. You know, I think it's very difficult to collect, you know, high quality evidence in this setting, but it does highlight, I think, the need for kind of ongoing registries to you know, to collect this kind of information. I think for me, one of the take-home messages is try to, if you can, try to avoid surgery in a high-performance athlete. If you operate, try to avoid fusion, and if you fuse as little as you can.
Yeah, I think those are all great points. Joel, did you have something to say?
Yeah, I'm sorry that the last speaker doesn't have a chance, and we don't have a chance to discuss that more, because I think that's the most practical thing on how to apply our, you know, what we do into everyday, you know, things that we see. So, you know, maybe, you know, this can be discussed again, but I just want to make one point. I had been very interested in and used the term stingers and what I call burning hand syndrome. This is stingers and burners. And if you go back to the original articles that are in that review, I'm not entirely sure that the article that you are reviewing took those original definitions and used them correctly. So it's sort of like this article is sort of secondary information of what the original terminology was. And that's really not that important. It's just that way you're discussing the stingers and burners as if they're all cervical roots, because in this paper they talk about that. I personally, based on the way I've seen these present in the past, like, you know, spearing is now outlawed in NFL, which would be a direct blow to the head, and that would lead to like a burning hand syndrome, like a mini central cord syndrome. A stinger, you know, a direct blow to the shoulder if you're tapping, which gets the brachial plexus. And the way this article was sort of discussing the return to play. It's almost like the stinger is due to a direct cervical spine nerve root type problem. And I just think it's very different. So I just think a discussion about the true version of what a stinger and burner is worthwhile. And you know, the original articles that paper was quoting may be worthwhile just reviewing. You know, does anyone else have any opinion of what a true definition of what stingers are and the cause of that? Because stingers usually unilateral, a burner is usually bilateral, and you usually get this burning hands type syndrome, which is very much like you know, I always called it like a mini central cord syndrome because it's bilateral.
I think your point's really well taken. So I think, you know, like a stinger is nerve root, so it's either plexus or the roots exiting from the cervical spine. It's unilateral and generally is benign and doesn't really result in longer term issues. So there isn't really an association with risk of further cord injury. A burner's bilateral hand is a spinal cord neuropraxia that requires investigation. So that raises concerns. And so, you know, it's a mild form of spinal cord injury. So I think that's kind of one of the take-home messages there to kind of make. There was some discussion on the Torg Pavlov. I would say that is for the history books. That's like pre-MRI. And the problem in some of these athletes is they have huge vertebrae and the ratios don't make any sense. And the reality is MR imaging is so easy now. So I think that's I don't know if any of the faculty are really, I learned it when I was a resident, and you know,
I think some of the plain x-rays, you actually lose some of the art of picking up some folks with congenital stenosis that you can get off a plain x-ray without actually having to go to the MR. But you know, I think no question, obviously there's better neural details, and you have to, you know, obviously consider the individual anatomy and dimensions of patients that you're talking about, recognizing a lot of heterogeneity in the population.
Anyway, great talk.
One more point, Joel. They said in that paper, they talked about the reduction in stingers after the introduction of shoulder pads, and hypothesized that it probably did come from brachial plexus. So it kind of was mentioned in that paper.
Yeah.
Okay. Well, maybe with that, we'll close out the session. Thanks a lot to the fellows, the speakers.
Thanks.
Thanks.
Good job, fellows. You did us proud.
You sure did. And thanks to Nadia for putting the session together. And
thanks everybody.
Spending the evening with you guys.
Participants. Thank you.
Have a great night.
Thanks, Ralph.
Be safe.